Hello and welcome. I'm Marun Sissodio. I'm one of the co-chairs of the National Network of Parent Care Forums, and I'm here today to introduce Sue North, who's the head of the Children, Young People's Learning Disability and Autism Programme at NHS England, and Ray James, who is the National Director for Learning Disability and Autism at NHS England. Sue and Ray have really kindly agreed to talk to us today at the NNPCF and Contact Joint Conference about the Learning Disability and Autism Programme for Children and Young People at NHS England. And with no further ado, I'll hand over to Sue and Ray.
Thank you very much, Murnal, and hello everybody. Really pleased that you're taking the time and we have this opportunity to share with you some of the important work that we've been doing at NHS England and improvement with and for children and young people and their families. That's both children and young people with a learning disability and autistic children and their families as well. Can I have the next slide, please? So the NHS long-term plan is the NHS's big set-piece national strategy that was published in 2019 and sets out the intentions of the NHS until March 2024. Now, obviously, this was written before the current pandemic, but it's helpful to begin with this really important and clear statement of priority for the first time ever in the NHS's big plan for the whole of the NHS. Learning disability and autism and children and young people are stated as a clear priority within that plan. And I want to go on to say a little bit more about the detail of that within the plan. Throughout the plan, there is a stronger focus on all children and young people, but the work that Sue will tell you a little bit more detail about in a moment centres around the work that we've been doing to try and improve the quality of life that many children and young people face with and in their local communities, and when they need specialist support to improve the accessibility and quality of that care, treatment and support. Next slide, please. We govern this work in a range of ways. I think important to say that we try and bring a lot of the national bodies together with parent carer representatives, with representatives from all of the bodies that you will see there. There's a board that has an independent chair. It also crucially has a cross-system working group, and our thanks to Runal, who's been an invaluable contributor to that group. And then we try and do the connecting with a lot of the other work that many of you will have heard about, and hopefully some of you may even be involved in other parts of NHS, the NHS and other partners, some work around special education needs and disability, mental health, health and justice, etc. We are terrible for our acronyms on slides like this, but I know just what a knowledgeable and involved group so many of you will be. So I'll ask for your forgiveness there. Next slide, please. So this is the one slide before I hand over to Sue in a moment that tries to set out the main themes of the priority areas of work within the long-term plan. Beginning with addressing the health inequalities that people with a learning disability and autistic people often face. So important, been highlighted yet again during this pandemic, and we know that across public service we must do more earlier in people's lives to try and address these health inequalities and help them live happier, healthier, longer lives as a result. So important work around health checks, around learning from the sad deaths of people through a structured programme of review and a range of improvements that we try and take forward there as well. Many of you will have heard about a programme that used to be referred to as Transforming Care, and a great deal of work to try and both reduce the number of times that people are admitted to specialist mental health settings, the length of time that they spend in them, and improve the quality of care that people receive. And elsewhere, you may have heard about the work of the Inpatient Task Force. I'm really grateful to the members of the Parent Council who have been sharing their experiences to help improve that work as well. The task force is one of the ways, next theme, that we are trying to improve both the quality of provision and the experience of people's care. You will see throughout our programme that we place a great importance on the contribution of people with lived experience and their families and carers to helping both to shape our plans, but also to monitor the quality of whether that work is doing what we want it to do. One of the commitments in the long-term plan, and we began with pilots this year and a further 15 million invested next year, is the development of key workers. These are skilled professionals with experience of working with some of the children and young people with more complex strengths and needs and their families to help bring the system together around them and improve access to and outcomes from the care, education and treatment that people receive. Sue will say more about co-production in detail in a moment. One of the best parts of my job is that we directly employ 6 people with a learning disability and autism and a couple of parent carers as well, who bring their lived experience into directly employed, including senior roles, within our programme to shape our plans and to help us deliver the training, support, information and guidance that's needed as well. And then finally, of those themes, we hear perhaps more often than anything else the difficulties that many families and parents have having to tell their story to numerous parts of the system, and the fact that things aren't as joined up as we would all like them to be. So Sue in particular has done a great deal of work over the years to try and bring together pathways across health, education and social care to make sure that the offer is joined up as it needs to be if it's going to make the difference that so many families want and need. That's all by way of a national introduction from me. I'm going to hand over now to Sue, who will take you through this in some more detail. Thank you. Sue, over to you.
Thank you, Ray. I'm just going to talk a little bit more about some of the detail behind some of the themes that Ray has outlined there, and wanted to start really with the commitment that we have across the whole programme and in the Children and Young People's team around co-production and making sure we hear the voices of family carers and children and young people directly. So I know this is something that you all are versed in, and I think from our perspective we are really committed to this underpinning all of our work as well. So many of you will know Mary Busk, who is our Senior Family Carer Advisor, one of the founding members of the National Network and the steering group. And we also have a young adult, David Gill, who is our lived experience learning disability and autism advisor, who really helps and drives the work around our engagement and participation with children and young people. So we know that in terms of everything we do, that co-production really needs to underpin and drive that. It's clear in the long-term plan, and it's clear in some of the responses that we've seen around COVID as well. So we have a parent co-production network. It meets termly. Mary and David lead that group, and we also have now some additional subject-specific meetings in between those termly sessions to support the co-production around specific elements of our work. And that, I think, has developed again in response to COVID and some of the increased challenges that we've seen. And I will come on and talk about that a little bit more later in the presentation. But I am just quickly going to run through in a bit more detail what our long-term plan commitments said. So all the things that we are still working on and regardless of COVID would have been working on. And then in the latter part of this, I'm going to just talk about some of the impact we know that COVID has had and how we've tried to adjust and respond to things. So Ray talked about what used to be called the Transforming Care programme, which was around our LTP, the long-term plan commitment, around reducing inpatient provision for those children and young people with a learning disability and autism in a specialist mental health inpatient bed. This is a small number of children overall, but we know that there are some real challenges for some of them around their experience and challenges around their discharge when they are inpatients in settings. So we, as part of our long-term plan commitment, have a target that no more than 12 to 15 children per million in the population will be cared for in an inpatient facility. And at the very end, we'll come on and show you some data around how that's going and what that actually means for local areas and how different areas are doing in terms of meeting that target. And again, just some details there about what that would mean in terms of numbers. So at its peak, we had 300 children that were inpatients. The target, the 15 children per million, would mean that we would be looking at 178 children. And as at September of this year, we had 205. So still a lot of work to do in relation to that. As I mentioned earlier, for our group of children and young people, often when they're admitted to inpatient settings, it can be particularly challenging to make sure that they are discharged when they're ready to be discharged. And some of that is about making sure that there is the right care and support in the community. So again, we are really committed to bringing down the length of time that children and young people stay in those inpatient mental health settings, and that it should only be for the time that they need to receive that treatment in an inpatient setting, and as soon as they're ready to be discharged, that everybody across the CCG, the local authority, working obviously very closely with families, are making sure that that discharge happens. And as part of that commitment in the long-term plan, it was very specific that we would work with partners to develop specialist community teams for children and young people. We know that for some of our children and young people, their admission to hospital is sometimes because they haven't been able to access that really specialist and intensive support in the community. And so perhaps as behaviours that challenge increase, or there are specific issues and difficulties with aggressive behaviours, that children and young people may find themselves being admitted, where if there was the right kind of service in the community, that may not happen. So again, the commitment is around increasing and providing that specialist support. So Ray has already talked a little bit about the long-term plan commitment for children and young people, and this is the wording of the commitment here. It followed on a recommendation from Dame Christine Lenihan, who again, I think most of you will know, following one of her reviews. These are our children. So initially, the commitment is around this support being provided to children and young people who are the most vulnerable, and by that we mean children and people who are in hospital or who are at risk of being admitted to hospital. And within that, that includes children and young people who are on the dynamic support register that local areas are required to maintain. So that's where we're starting, but that it will be extended, particularly in kind of the latter year, to other groups of most vulnerable children and young people. So Ray again mentioned earlier about the health inequalities we know that lots of our children and young people experience, and there had been a really effective pilot project that was being undertaken with our colleagues in the ophthalmology team and a charity called Seeability around really supporting children and young people with a learning disability and with autism to have their vision checked in school and to have that proper ophthalmology check. We know for many of our children, kind of going into town, sitting in the chair, being able to do the tests in the way that perhaps you or I would, can be really challenging sometimes. And for some children and young people, that may mean that if those adjustments aren't being made to support them in the community, that actually they may not have their vision checked, or their hearing checked, or their teeth checked. And so the commitment was made in the long-term plan about us bringing those checks to children and young people in special residential schools. So we know that that's a small group, but again, a kind of a really important group, and we are looking at how we can kind of do that. This is a brand new commitment. We've never done it before in this way. So we are working hard, and I'll talk a little bit later about how far we've got with that work. There are also other commitments in the long-term plan. Some of you may have been involved with the Stomp and Stamp work, which is about stopping over medication, supporting appropriate treatment and medication for children and young people with a learning disability, autism or both. There's a commitment around our work with the Department for Education and with local authorities and areas to improve and support that awareness and support for children and young people. And Ray talked a little bit earlier about some of the governance structures and the ways in which we work with the Department for Education. There also was a commitment around autism diagnosis and looking at how we can implement the most effective ways to reduce waiting times. We know that's a really big issue for lots of families and in lots of areas. And about improving the uptake of existing annual health checks in primary care for young people with a learning disability who are over 14 years of age. So you may or may not be familiar with that commitment around young people and adults having an annual health check if they have a learning disability. That's because we know that there are some particular health inequalities and challenges that that group face. So really important to have that annual health check. And our commitment is to make sure that at least 75% of those who can are having that health check. It's obviously a choice for the individual as well. So in line with some of our commitments around the inpatient provision is also the commitments around improving the quality of care. And some of you will be familiar with a lot of the shocking stories that we've heard about how some children and young people experience their care and treatment in hospital and what that actually means for them, and particularly if they are in long-term segregation or seclusion. So we've been working within NHS England with the Care Quality Commission, with the Department for Health and Social Care, to consider and develop a whole range of things that, again, I'll talk about in a little bit more detail around the Quality Task Force that Ray mentioned, around how we can address and implement the recommendations of these reports. There's also a range of other work that we do within our team and our programme. So we work with the CAMS Clinical Reference Group. We have a specific subgroup of that clinical reference group for children and young people with a learning disability and or autism. And you can see on that slide some of the things that we look at within that. The independent care education and treatment reviews are part of that response to the interim CQC report that was published about those being cared for in long-term segregation and seclusion. And so there is an oversight panel chaired by Baroness Hollins that has led on a review of those people, so not just children and young people, also adults who were being cared for in long-term segregation or seclusion at that time. There have been 77 reviews from that, and Baroness Hollins is working on the findings and the recommendations for that report. And some of you will also be familiar with provider collaboratives, which are a new way of delivering mental health services and provision. There are 10 provider collaboratives that are now live across England. There's a whole different webinar that could be done around provider collaboratives, and there's lots of information on our NHS England website if you want to know more about those. There's also a range of other things that are on this slide that as a team we have been involved with or are leading on. So we've done some work around family trauma, trying to recognise the trauma we know for families that particularly who find themselves with their child being admitted to hospital. It can be really a very traumatic experience for everybody, and some of the other processes by which we look to improve on the quality oversight and assurance for children and young people if they are in those mental health hospitals. So I am going to come on now and talk about COVID-19 and the impact that has had and some of our response and things that we have tried to do or implement in response to some of the real challenges and difficulties that children, young people and families have faced during this time. So I think we've heard from lots of families, from lots of our stakeholders that we work with, and from lots of children and young people about the real difficulties that the pandemic has brought for children and young people, and how some of the restrictions that are put in place to try to kind of manage those risks of transmission around COVID have had a really kind of perverse negative impact for some of our children and young people in terms of those restrictions of social distancing, the issues around the school closures initially, challenges around being able to go out and exercise, the issues we have seen around wearing face masks and some of the real challenge that is for our children and people, and then some of that public kind of response if they're not. We know that there's just lots and lots of things that have caused real challenge, but that isolation, that the change in routine, all of those things have just been a real challenge. So we know in lots of our families that we work with have reported to us, and through the national network we have heard those messages around the impact on families, about the increase in crisis that families are experiencing, the fact that lots of the services that may have been there to try and support that changed or were suddenly not there, and support was not available in the way that it was. And then all of the issues that COVID itself brought. You know, lots of people have experienced bereavement, with family members being ill. If people with a learning disability and autism have been in hospital, challenges around visiting, all of those kind of things. So we know that this has been a particularly difficult period of time for children and young people with all types of disability and their families. So within NHS England, obviously some of our work has been around having to deal and try and manage and support the COVID response in our programme, and Ray, kind of leading as a real champion, has tried to ensure that as some of the policies and procedures and guidance around COVID have been put out, that the considerations that needed to be there around children, young people and adults with a learning disability and autism have been considered, where we've been able to do that before they've gone out, or where there are things that have needed to be changed, has really championed for that to happen as well. So what I did want to do though is just talk a little bit about what we've managed to continue to carry on doing despite COVID, as well as then some of the things that we've done to try to respond to COVID. So we talked a little bit earlier about co-production and our commitment in the national team. And we are also obviously really encouraging all of our regions to work collectively and in co-production with parent carers and with parent carer forums. And we just had a really positive example about in the Southwest that has happened. Some of you here may be from the Southwest and be part of this work. But I think that this just demonstrates what value kind of that co-production work with parent care reforms can have. And so if within your regional network you perhaps are not as well linked in with your regional colleagues, it's really worth thinking about how that can happen and how the region can help support that participation and co-production as well. So I talked a little bit earlier about some of the particular challenges, and I think you know, our commitment was about trying to reduce the number of children and young people being admitted to hospital and supporting families in crisis. And then the position we were in clearly was that lots of families and young people are in crisis because of all of those challenges and issues around COVID. So At the start of the pandemic, we saw an initial reduction in children and young people being admitted to mental health hospitals and an increase in the discharges of those children and young people that were in hospital. But in August and September, we saw a surge in admissions, and we were really concerned about that and about whether that was going to continue. And what we saw that within that group was that it was primarily autistic young people. Sorry for the wording on here, it's not very helpful, with an increased acuity, which just meant they were presenting with very severe kind of mental health crisis when they presented. So we worked across with all of our colleagues in NHS England, with the Department for Education, with parent care representatives, including the national network, and with some voluntary sector partners, to think about what we could specifically do to try to increase the support in the community and to make sure that those children and young people that may be experiencing the most distress were getting the right response and the right support, and that we were ensuring that we were preventing any unnecessary admissions where that could be provided in the community if there was extra and additional support available. So we had a specific plan with increased awareness and vigilance and monitoring around those inpatient admissions, working with all of our regional colleagues. There was also a commitment that for everybody, that the mental health crisis support lines that offered a 24 hours a day, 7 days a week support would be available. That was a commitment that was made before this work as a part of the pandemic response nationally across mental health. But we have done some work and offered some support to the people on those lines around making sure that there's a reasonable adjustments. And so if young people who are autistic or who have a learning disability trying to contact them, or families, that they have the right skills and knowledge to know how to support those individuals in the best way. We did some work with Sendias services, again, just looking at how they could help us manage this. And some of the things that we also looked at was how we could really strengthen the dynamic support processes. And I mentioned a little bit earlier about dynamic support registers, to make sure that local areas were really identifying all of the children and young people, including those autistic young people who may not be on their dynamic support systems and at risk of admission registers, to make sure that they really knew who they were and that they were on those registers, and that that right kind of local collective support around the child was being offered for those. So that's kind of a summary of some of the work we've done around admission avoidance. So for our key working commitment, we had been really positive and I had hoped that we would have pilots for key workers this year, and obviously the COVID pandemic impacted on us rolling those out as quickly as we would have liked. However, we were still able to progress with looking at how we could roll out the key working pilot for this financial year in a shorter time scale. So looking at pilots kind of starting from September time, and in essence, actually, we have more pilot sites because we had a shorter period, so more resource to be able to look at how many pilots we could mobilise. So within each region, there were expressions of interest around the key working pilots. We had specifically asked within those expressions of interest that there was a demonstration of how CCGs and local authorities were working collaboratively and in co-production with parent carers and parent carer forums. And we know that many of you were involved with that, but we do know as well that the timing was really tight, obviously not great over the summer holiday period, particularly when so many children have been off school for quite a long time before that as well. But we do thank you very much for all of you who were involved in supporting your local area expressions of interest for this. So we have 13 pilot sites that cover 35 local authorities. They have varied team structures and skill mix, and that's part of what we're piloting, is looking at what works well. We have some that are working with children up to the age of 18 and some that are working with children and young people up to the ages of 25. We have a community of practice, and we have plans to expand that to early adopters next year with full coverage by 2022-23. So these are the 13 pilot areas, just for your information. So a brief update about where we are with the dental sight and hearing checks in residential special schools. So again, we had planned to pilot over this year. The plans were clearly delayed due to COVID-19, and so lots of our colleagues in those different primary care services were also redeployed at that time. However, we are back in action, and we have across all three some pilots beginning in January, restrictions permitting, and all three elements are at very different stages. So I mentioned earlier that some of the commitment was based on the work that had already been done around the eye tests in schools. So for ophthalmology, they're already well developed in terms of their concept of delivery. They're looking at how that can be commissioned, and how we can roll this out in residential special schools. But in terms of the process in which that is going to be rolled out, and the general ophthalmology contract, there's potential actually for that to be rolled out much wider than just in residential school settings. So for our colleagues from the dental team, they're not quite as advanced in terms of where they are, but are doing some work, and will be piloting again from January to March, working with schools around mini mouth care matters, looking at doing some virtual checks, and working on their commissioning standard around that dentistry offer. And then for hearing, that's probably been our most complex area of work, because the checks around that are delivered and commissioned in a very different way. But our colleagues from the hearing team again have some pilots that will start working Q4 that will be linked to the specialist audiology services, and we'll be looking around how we support parents and caregivers in doing some of those virtual outer and middle ear health assessments. So delayed, paused, but we're back on track, and are hoping that next year in particular we'll be able to continue and deliver that. So we've already talked about the Quality Task Force, and Ray mentioned it earlier as well. So this is a children and young people's quality task force that is specifically focused around the quality of care in inpatient mental health settings. It's not just for children and young people with a learning disability and autism, it's for all children and young people. And it has a really broad programme of work. So this slide just sets out some of the long-term vision and the 5 areas of ambition. There's really significant programmes of work under each of those 5. I could talk to you for another hour about those, but I won't. But there again is information on the website. The Quality Task Force Oversight Board is chaired by Anne Longfield, the Children's Commissioner. But we do know that for our children and young people who are inpatients in mental health settings, again, there's been some really significant impacts because of COVID-19. And some of that initially was around the visiting to anybody in hospital, and the guidance that came out around that, and some of the blanket restrictions that were placed in relation to people visiting. And in light of some of the quality challenges there are, we know that that placed extra stress on both children and young people and family members. Some of the meetings and processes that we have in place, again, in terms of ensuring well-being and making sure that plans are progressing as they should. So the care education treatment reviews and the CPA, the care program approach meetings, for many moved to being virtual meetings. So we were very clear that they shouldn't stop, but clearly in terms of the numbers of people going into those settings, we had to consider how they could best be done, but appreciating that it perhaps does not give that same level of oversight as a face-to-face meeting or visit would at all. We know lots of providers had staffing issues due to illness. For children and young people settings, there's been a number of settings and wards that were closed because of quality issues. And for some of our children and young people that were had discharge plans, or where there was work going on around either providing or developing their community support packages, that it's created some further delay to those. And lots of our focus groups and surveys and all of our co-production work that we would normally do face-to-face, again, had to be done virtually. And that delayed some of the specific work we were doing around the children and people's restricted practice resource. So we've tried really hard to put some mitigation in to try to address some of those things. We've had some clear guidance from both Ray and from Claire Murdoch, who's the National Director from Mental Health, around visiting. We have some processes in place around quality assurance and other work that we've continued to progress in relation to some of those things. So annual health checks, again, the phase 3 letter it has really reminded and pushed everybody to make sure that now more than ever, having that annual health check is really important for people with a learning disability. So as a programme, we're funding a range of exemplar sites across every region, and there are 2 that are specifically for children and young people. One is in Derby and one is in Lancashire, around increasing the numbers of children on the register and increasing the number of children having annual health checks, and we will gladly share the learning from those. So we'll just finally come on to looking at how are we doing then. So we've got all these commitments, all of the ambitions that we have, but how does it translate and what does it look like? So this is specifically in relation to our children and young people who are in inpatient mental health settings. So you can see that we have had a significant decrease, but we're still not where we would want to be. And we have a lot of work to do in terms of getting to where we need to be. So this slide here just shows you how actually local areas are doing. So you can see for yourself where your local area sits in terms of this. So in the green, you can see areas where they're already meeting that target of having 12 children or less per million. And you can see then in the darker grey, those who are meeting the 13 to 15, and then those who are not shaded are the ones that are outside of that 15 at the moment, and the areas that you know, will need to work hard to make sure that they meet those targets. But I think for us, one of the particular things that we are aware of is the population of our children and young people who are in inpatient mental health settings. So you can see from this slide, in March 2015, at 31% of our children and young people had a learning disability, 20% had a learning disability and autism, and at that time, 43% had autism. So we think in those first 2 years in particular, that probably the numbers of children with autism and no learning disability was underreported. And that was often, I think, because those children may be admitted because they've got an eating disorder or mental health crisis or worse, harming. And the impact of their autism on their mental health or their presentation was often considered a secondary issue. Even though we know that it's really important in terms of making sure that treatment and care is reasonably adjusted and thinking about the particular support that they may need on discharge. So we, as a programme, kind of gave some very clear directives around that time about making sure that group of children and young people were being included. And I think you can see that in the increase that we see significantly from March 17 onwards. And as you can see, we have a significant reduction in the number of children and young people who have a learning disability who are now in hospital. So that's an 86% reduction. We have a significant reduction of children and young people with a learning disability and autism, but we have a significant increase in the number of children who have autism and no learning disability. So we know that is a real concern for us and forms part of some of those commitments in the long-term plan around autism in terms of helping us address that. And I think for local areas, many of them clearly recognise that support, the early support and intervention around autism needs some significant development. So that brings us to the end of the slides. We just wanted to let you know who in your regions are the key children and young people's leads around learning disability and autism. So their names and their emails are all there for your use. If you don't know these people, it's definitely worth getting to know them, and they will be, aware and up to date of what's happening in your regions and how they're supporting the local areas in terms of delivery around all of these commitments. So thank you very much. I'll take a breath and hand back.
Thank you, Sue, and thank you, Ray, for that. I think you've given us a really good overview of the work that you're doing as a part of the long-term plan, and also a good understanding of the areas of focus that have come out of some of the crises that we've had in the system recently when it comes to particularly things such as admissions avoidance and also, of course, COVID-19. Now, this is a recorded session, but we have reached out to our network and asked our members if they have any questions for you. And so what I've done is over the last 10 days or so, we've been getting a steady stream of questions from our members. And what I've tried to do is compile them into themes, if I may. And Sue and Ray, what I'd like to do is put some questions to you from our members about some of the topics you've touched on. And I'll also reference where we've had questions where I think you've already answered the question, so that people know that we haven't ignored their question at all. But I'd really like to start, and I think I'd like to break the questions into two broad groups. The first being around the long-term plan, and the second being around sort of COVID and what's happened there. So really, one thing you didn't touch on, either of you, was actually the wait times for diagnoses for autism in particular. And many of our members still report very long wait times. 2 years is not unusual, and often a minimum is what many areas report. Now, this is clearly far too long to wait for a diagnosis and to wait before anybody gets help. Can you tell us a little bit about what you're doing around that and what your thoughts are?
Thanks very much, Runa, and agree and completely recognise the issue. The long-term plan acknowledged the need to do more around autism diagnosis, and it committed to beginning by trying to improve the screening and diagnosis arrangements for children and young people with the most complex of needs in their families. We hope that through making a start there, that there will be improvements for the rest of the system. So 3 quick things to say by way of a bit more detail. Firstly, we have pushed for more transparent publication of the data about the different periods of time that people are waiting in different parts of the country, just to shine a light on that and through the comparison to encourage improvement. The second is to say that we hope that arrangements will be coming fairly soon where people perhaps will have the opportunity to choose who the NHS provider of that autism diagnosis ought to be, in the way that, for example, some people here may know that you might choose and book other procedures, normally kind of treatment procedures or surgery, this would be potentially an opportunity to choose who might do the assessment. And I think in that way that might drive some of the organisations that are better at this to be able to offer a service to others. That's not confirmed yet, but helpful to share it as one of the areas of work. And then finally, we expect, a bit like we've done for key workers, to be piloting some different approaches to screening and assessment with children and young people during the course of 2021-22 to begin to address the issue. Fundamentally, this will be about a workforce challenge and having more people trained with the ability to carry out earlier assessment and diagnosis for autistic young people and their families. I would also hope that many of you might be making similar points when you're talking to colleagues from DFE about the SEND review and the importance of earlier help and support there as well. And we in health would want to continue to work with DFE colleagues. So really valid challenge. It's going to take a few years to sort it, but hopefully given people listening some sense of the range of ways in which we're starting to try and make a difference.
Thanks, Ray. And I think that your point around more transparency around waiting times is really interesting, because I think that one thing we have observed is that sometimes what you measure in this system is what becomes important, and therefore providers will focus on that. And to your point around working on the SEND review, rest assured that we are making this point very loud and clear to the SEND review as well. Just building on something you said there, Ray, and just moving on a little bit, which is actually about early help. That again, a lot of the help that families are reliant upon in this space is dependent upon a diagnosis. And you know, our mantra has always been, actually we should always support the child, not treat the diagnosis. And I think that there's a real urge from us to move away from that medical model and to listen and co-produce with children, young people and their parents, and to intervene early. Can you say a little bit more about what the early help offer, how the early help offer is being developed in this space, and the sorts of early help and interventions that families might be able to expect?
I'm sure Sue will want to say a little bit more about the detail here, but I would want to simply say that at a national policy level across education, health and care, I think more and more people are beginning to realise that it is much better to think about how can you intervene as early as possible and provide some sort of tailored early support, whilst you might then think about what needs to happen in terms of formal diagnosis and pathways for that. So recognise what people are saying. Sue, anything more you'd want to say on the detail of this one?
No, I think just to kind of reinforce, Ray, what you're saying, I think that collectively we have an understanding about that, the value of early help and the impact that has both for children and for families. You know, I think for us, we know, for example, that the pathway of for lots of our children, you know, involves kind of school exclusion or school refusal. So something at that earlier stage may really help support that. So, you know, there's been some activity that we've been working on. So last year we had the Children and People's Accelerator site work, and I think one of the most successful elements of that was around the Cumbria and the North East work that they undertook, which was led by actually the Parent Carer Forum network there, that was around that earlier intervention in schools, supporting schools to look at how they were addressing and supporting the needs of children and young people, you know, that were presenting with challenges where perhaps that may have led to that. So I think, you know, there are pockets of work that are going on, and I think collectively we recognise the real importance of that. And I think as part of the work of the SEND review, our own governance structures and the work that we're doing, we'll all continue to keep making the case and pushing for that early help and earlier intervention.
Thanks, guys. I think that's one of the big themes for us into the SEND review. And Sue, as an aside, I was this morning I was giving evidence to the Education Select Committee on home education, And I referenced the North East Accelerator site as a really good example of where early intervention could change trajectories. So I think that work is being recognised. I want to sort of build on this point around early intervention a little bit, and move on to perhaps, you know, admissions avoidance. You did talk about that very explicitly in your slides here, but the feedback we're getting from our forums is very much along the lines of that there just doesn't seem to be enough urgency in this, and the messages just don't seem to be getting through. So, you know, one email that, you know, I'll quote from you know, one of our members: when will the NHS stop commissioning hospital places for autistic children and those with learning disabilities, and start commissioning support in the community instead of passing it up to local authorities? And there's that very much that cry from our group around early intervention, helping the community, and the difference that makes to admissions avoidance. Can you say a little bit about that?
So I think, again, in the long-term plan, we really recognise that, and that there is investment in the system that will begin next year that's around that support and development of community services and provision. We know some areas, you know, have already started some of that work, but some have not in the way that we would like. So I think we recognise absolutely there's a need for more and greater pace. We know that community investment potentially will minimise and help us with the admission avoidance that we're looking to do, but it is, you know, it's challenging in terms of the footprints around the cover and how that works, and so it's really important around how local areas and local communities consider how that's being offered and supported. But there is a commitment in the long-term plan. Ray, I don't know if you want to say any more about that.
Yeah, and I'm going to be a little bit provocative here, quite deliberately. So I had a career in social care for a lot of years, as you can tell from the grey, before I was asked to come across and take on this role with the NHS 3 years ago. So having seen this from both sides, as it were, the areas that do this well tend to put their money together across health and care and have a shared plan about how it should be spent, rather than have unseemly arguments between health and care about who's paying for what. Those areas nearly always have an active parent-carer forum who are an integral part of those plans, helping to co-produce them and to check whether or not they're doing the things that they said they would do. Equally, I've recently had cases of local authorities looking like they're trying to insist that a placement is necessary in a hospital because the local authority can't support the person, or perhaps during the pandemic particularly struggling to source staff. I think that's an admission in those circumstances is the last thing that should happen. A young person with a coexisting mental health condition who also has a mental health condition should only ever be admitted to hospital where treatment can only safely and appropriately be provided in hospital. That should be for the shortest length of time possible, and always with a view to what needs to happen for discharge. In addition to the key workers that Sue has talked about, we've also introduced some roles that have tried to help with the most complex of circumstances to try and make sure that in that particular local area, education, health and care work together to try and ensure that that young person has a better future. Perhaps most importantly of all is the importance that we're placing on dynamic support systems. Some people have called them dynamic risk registers. This is where we think every local area should be monitoring those young people who perhaps have the most complex of strengths and needs, or going through a particularly difficult phase, and looking at what is it that they are doing to provide support in the community as an alternative to an admission. And indeed, we're making more money available for community services in each of the next 3 years, alongside the money that's being made available for key workers. So I'm not a great fan of trying to apportion blame between health and social care. I am a big fan of trying to make sure that health and care come together in the local area, that they spend their public money to best effect. And normally, if they're involving parents and people with lived experience, they'll make much better decisions too.
Thank you, and I couldn't agree more. I think that the when a child is failed, it's a collective failure, and when a family is supported correctly, it's almost certainly going to be a collective success. And I think we just got to keep that we as parent care reforms live that mantra of co-production and collaboration, and we just need to continue to push that down through all levels of the system.
I think, Bruno, the slide that Sue shared earlier that shows how many young people are in inpatient settings up and down the country, it will be worth the local parent carer forum saying, why is a young person twice as likely to be in an inpatient setting in our area as in some other parts of the country? And again, using that transparency about the data to say, and how much money is being spent on that, and how could we help you spend that better with local community-based support.
Yeah, and I think we'll be distributing all the slides as a part of the pack for this conference webinar. Thank you. I just want to talk a little bit about learning disability annual health checks. So we've had a number of questions around this, and there's genuine confusion about who qualifies. The categorizations between the learning disability and associated learning disability, a learning difficulty, and I suppose the challenge is really around clarifying that in a way that we all understand and the GPs understand, but also what are we doing to make them genuinely mandatory and of the right quality? What can we do to automatically flag and identify those children?
In terms of the issue about definition and who's entitled, it's meant to be people with a learning disability age 14 plus. Worth a quick mention that we're also piloting health checks for autistic people, and have got 6 or 7 sites across the country with the university helping with the evaluation. So hopefully in years to come there may be an evidence base for annual health check for autistic young people as well. But back to the ones that happen at the moment. There's huge variation again in terms of the numbers that are done. There is some work happening around something called a digital flag, which will go on every person's health record, not just to trigger the issues in relation to the health check, but also to share with clinicians in other settings. Perhaps if a young person needs to go to a hospital for appointment, that digital flag will say that they have a learning disability or autistic, and it will also record the reasonable adjustments that that young person or their family have already said are important. For the health check itself, completely agree. The health check on its own isn't really meaningful unless it leads to a good quality health action plan at the end, which will kind of set out what needs to happen, what the risks are, and what the interventions and follow-up should be. And it's worth saying also that currently these tend to happen in primary care with GPs, or perhaps with a practice nurse and the GP overseeing it. We're thoughtful about whether or not there might be other people who could help to try and ensure that annual health checks are carried out in their local area as well. So I was hearing about a social enterprise in the northeast of the country today that employs 3 people specifically to work on the health checks and the follow-up. And I was interested in that because they seem to have some real tenacity about making sure that all of the follow-up is happening, people whose dedicated roles it will be. But then equally, it's quite possible that a young person with a learning disability may be amongst the people on the GP's list who's got the most complex of health conditions, of physical health conditions, alongside their learning disability. So it needs to be individually based and making sure that we're getting the right level of clinical expertise involved where it's needed as well. I think the issue about who gets it, I'll stop trying to say that word, is one that has been challenging up and down the country, and we are trying to gradually get to some greater consistency. We encourage, if you're in doubt, that actually then you should probably do a health check, because it will definitely benefit the individual for the longer term, and it will almost certainly save the NHS money as well as improving outcomes for the individual person as well.
Thanks, Ray. I think that's a really important steer, that if you're in doubt, do it. I think that's a message that we can get on board with and push forward with. I'd like to sort of move us on to coronavirus, and I think that, Sue, in your slides you did talk a lot about the impact that coronavirus has had on the learning disability and or autism community, and we're all very painfully aware of those health inequalities, and it's not just health inequalities, it's life inequalities that this group faces, and obviously you know, the coronavirus just doubled down on that for us. It's the sense that we get, you know, the very disadvantaged people further disadvantaged, not only by the virus itself, but by our response to it as well. There's a couple of specific questions I wanted to ask about. The first is around Down syndrome. So if I might be able to just again read something to you around from a parent of a young person with Down syndrome. I have a young person, 19, who has Down syndrome and has been placed arbitrarily in the clinically extremely vulnerable list. They have now been asked not to attend school. Parents have had to take time off work to help homeschool him again. Although colleges have been great about setting up Zoom calls, the lion's share of the education is still falling to the parents' shoulders. Just 2 weeks into lockdown 2.0, and the young person is refusing to do Zoom calls, is withdrawing from any online social interaction. This is a time he should be developing these skills ready for the workplace. Can you say a little bit about the inclusion of young people with Down syndrome on that clinically extremely vulnerable list came as a surprise to a lot of people? Can you talk a little bit about that process, or a little bit about what we can do about stopping these sorts of things happening in the future?
Yeah, so that decision was taken by the chief medical officers of England, Scotland, Wales and Northern Ireland, who arrived at a unanimous decision to place all adults with Down syndrome on the clinically extremely vulnerable list as a result of a data study led by some people at Oxford University, which looked at the records of over 2 million people in primary care and the outcomes that were happening when people caught COVID. So this wasn't about the increased risk of catching COVID, but it was about groups of people who were having worse outcomes from COVID. They took a decision to add 2 groups of people. One was adults with Down syndrome and the other was people with stage 5 kidney disease. Now, there has been some discussion amongst a range of stakeholders about the comparative evidence for this. And I think the evidence internationally is probably strongest about older adults with Down syndrome and the heightened risk. Lots of people would say that the evidence, for example, of adults with Down syndrome, say age 40 plus, is stronger than it is for all adults. And that's partly about the presence of coexisting health conditions, obviously. It's also partly about early onset dementia that is more prevalent in adults with Down syndrome as well. But look, these are eminent clinicians faced with a body of evidence who took a decision to add people to the clinically extremely vulnerable list. What we did for our part is say that we still thought those should be individual decisions managed through people's GPs. And so there is scope for, in the case that your discussion, a conversation to be had with the GP in order for that GP to arrive at a clinically based decision for that individual about whether or not they should be on the clinically extremely vulnerable list. Now, 2 things to say about that. One, look, let's be straightforward. It's going to be unusual for a GP to go against the weight of the decision of the chief medical officers of the country and the evidence that's there, but it should be an individually based decision. The other thing now is that we've already seen that people who are on the clinically extremely vulnerable list will be amongst the early groups prioritised for the vaccine. And also there are other support that is available to people who are on the clinically extremely vulnerable list by way of kind of access to community-based support, priority shopping slots, some of those other things that people have known about. So I think national policymakers have tried to balance the risk to people's liberty and their wider quality of life with those circumstances where the greatest risk exists. We have tried always to ensure that wherever possible, they are individually based decisions rather than blanket decisions. but the really difficult kind of judgment for a GP to make, given the evidence that there was in the study about the outcomes for so many people with Down syndrome.
Thank you, Ryan. I think I think everybody understands that this is a really difficult topic, where you're balancing up the medical risks to a broad brush group of people versus the other disadvantages that they will face. And I think that the feedback from this was two things. That there's a sense from the community that, as you say, that perhaps the under 40s could not have been included in this group, and secondly that there was not little advice around co-production when it was put out there. But one of the things we have learned going through the coronavirus pandemic is that we've iteratively learned and got a little bit better at the way that we do things, and more and more reasonable adjustments and more co-production has entered the guidance over time, and we hope this will be the case in this instance as well.
Yeah, a couple of other thoughts briefly. Look, one, just to say, Sue specifically raised the example. She actually talked about a 19-year-old adult at college to test the kind of wider ramifications of the decision. So just kind of wanting you to say that we were trying to make sure that these sorts of considerations were a part of the decision-taking process. And one of the things that the people from the CMO team said to us is a reminder that this is advisory. So I think what they were saying from that is that they recognised that there was a balance here. They felt duty bound to give their best possible advice to everybody based on the risks that they understand. But ultimately, it is advisory rather than mandatory. Now, that's difficult for families when schools, colleges or other people take decisions off the back of it. Absolutely. But it's worth being clear that it is advisory.
Yeah, and I think that's the key point, is that even with co-production and even with the advisory tag, that the services were unilaterally withdrawn. I want to move us on. You mentioned the last question, just sort of looking forward, is you touched on this, Ray, as in, will children with learning disability and or autism be prioritised for the coronavirus vaccine, given the disproportionate impact the virus has had on this group? There's awful stats floating around about death rates for people with learning disabilities and autism. But what can you say about that process of getting this group of people prioritised?
So this may change, and probably important for me to say that I'm recording this at almost 5 o'clock on the 24th of November. So things may or may not have changed by the time that people see this. But as we speak today, we have made sure that the evidence has been shared with it's called the Joint Committee on Vaccines and Immunisation. So the latest evidence was a study by Public Health England, and we commissioned the University of Bristol to have a look at the deaths of 206 adults during the first wave of the lockdown. The numbers are really small in relation to children, and so I've not seen any suggestion about children or young people other than those who might have some of the physical health conditions being considered in amongst the vaccination group. But to take the question that you put more widely about adults with a learning disability as well, we've tried to ensure that the best available evidence is put before the decision takers in order that they can do that. And also important to say that we've got a member of our team working with the COVID vaccination team in terms of the planning, because there's two things here. This isn't just about who gets priority. This will also be about, can reasonable adjustments be made in the way that the vaccine is delivered? So just to reassure that we've got people helping with the planning on that important point as well.
Brilliant. Thank you, Ray. Thank you, Sue. I think you've presented a really thorough overview of the work that you're doing and the long-term plan, and I'm really pleased with the way that the transparency and the honesty with which you've answered the questions that have been put to you. So with that, I'd just like to say thank you very much for joining us today. I'm sure that our membership would be really interested in what you've had to say today and when this webinar goes out next week. And with that, I'll say goodbye, but give you both the final word if you want to.
Thank you, Marunal. I think really I would just want to say that all of our work has to be underpinned by our co-production with families and with young people. So, you know, I appreciate that for the national network, your remit is around all children and young people with disabilities, not just our group with a learning disability or autism. But we really welcome and encourage your forums to think about how, if you aren't working with your regional colleagues, you know, your voice is really important and will help to influence and support delivery for not just our group, but then how that works across your regions and your local areas for all groups. So please, thank you if you're already involved. You know, I know that there are lots and lots of demands on your time, but if you're not and you want to, then please do get in touch with your regional lead.
And from me, firstly, thank you to the National Network for the interest that you've shown in the work that we're doing around learning disability and autism, for your contribution to that work as well. I remember in the early stages of the first wave of the pandemic, we lobbied to try and get some changes to the rules about people going outdoors and being able to take some exercise before all of that had been sorted out. And you kindly shared with me a letter from the mother of an autistic young person about the profound difference it had made, that one simple, straightforward decision on their life. And I used that example anonymously when I was talking about things as well. And frankly, in microcosm, here was a parent with all of the additional challenges and fantastic aspects of their life with their young person, in the midst of a pandemic, who took the time to write and say thank you. That was in microcosm a reflection of the generosity of time, of experience and of insight that so many parent care and forums up and down the country so freely give. And people like me could not do our jobs without it. So I just want to end with a huge thank you for what you do and a plea for you to keep on doing it as well as you do. Thank you.
Thank you, Ray. Thank you, Sue. That's been a really full hour and 10 minutes or so. And rest assured, we're passionate enough that there's no way we'll stop working with you to improve the lives of kids like ours.